The first case is a 64-year-old female who has a long-standing history of lupus, for which she's been on chronic steroids for about 40 years. So you can imagine what that means for her bone density. She has known osteoporosis that's been treated. She had an L5-S1 small surgery done about 6 years prior to me meeting her, done at an outside hospital, and you'll see I'm not sure exactly what the goal was with that surgery, but you'll see when I show it to you. And now she presents primarily with just back pain and difficulty standing and moving around, although physical exam otherwise is pretty normal. This is her imaging here. So you can see the parameters are listed as such. She's got this sort of unilateral hardware at L5-S1 where she had a lysis and a listhesis. You can see she's had multiple joints replaced and clearly a very positive sagittal imbalance with a high SVA even for her age. Now you can see interestingly that this deformity is extremely flexible. So when she lays down for her CT scan, she corrects very nicely, and I'll just run through the scan here. And her coronal plane corrects pretty nicely as well. So she's got pretty significant facet arthropathy, especially at L3-4, distal at L2-3, arthrosis at L5-S1. So really coming with a lot of different issues here, but a very flexible deformity when you compare her standing films to what she looks like when she lays down. So from the panel, any thoughts when you have a deformity that's this flexible, just in terms of treatment? Abhay, do you want to start?
Is she disabled enough to need any intervention? I didn't get that.
Yeah, she cannot walk. Like she's totally fine when she lays down. Minute she gets up, she's having a very difficult time walking. And right now, 64, but on chronic steroids. So, I think her thought is, and I think appropriately, do something now or, sort of never do anything.
I think it's a fair call, and, you would be tempted to take care of this and do a similar procedure as we saw for Ankur's case, like a full big long fix and follow up with teriparatide maybe, do an interbody at that one level where it's collapsing.
So you would do somewhere in the thoracic to pelvis with inner body fusions where you can
at least at one level, yeah.
Is that we could just go down the panel real quick and then I'll show you guys what I did. Do you want to? What would you do here? So I'll just jump to the MRI as well, so you can see that there's really minimal stenosis issues. Really, as you could see, again, also on the MRI. Sort of things look pretty reasonable, some lateral recess stenosis, but essentially a significant difference between standing and laying down, as you can see here on imaging.
So when she stands, it's predominantly back pain, or it's
yeah, it's the kind of pain that the sagittal and that lower back, buttock, hips area that she just feels pain, and then she feels like she's falling over.
Okay, she doesn't have a radiculopathy or a claudication. No, it's mainly back pain.
Yeah.
Okay, and have we tried any brace treatment for her or anything?
Yeah, I don't think she tried bracing, but lots of physical therapy, lots of injections. Nothing has helped her, and her body habitus is probably not one that would be very good for bracing.
Okay, so if it is mainly back pain and it's a flexible one, and if the spine collapses like what it is collapsing as soon as she stands, so I agree with Dr. Nene that we need to go somewhere in thorax to pelvis.
Yeah, and I show just the X-ray so you can see all the folds. Very hard to brace somebody of this body habitus. Last two, again, what do you guys think?
Agreed with Dr. Nene. A long fixation, if at all it comes to surgical, then right from T10 to S1 again, with interbodies at 3-4 and 4-5 level, and post-op teriparatide for sure.
And you guys would all do this from the back, posteriorly?
Yeah, all from the back.
Okay.
back.
And last?
I would really exhaust my conservative trial before offering any kind of a surgery, because I'm not sure what kind of a pain she's having. Is she having osteoporotic back pain, or is it because of the pseudoarthrosis? Is it because of the altered alignment and more of a fatigue paraspinal pain? So I would really do all facet blocks, everything before offering any kind of a big
Yep.
in this.
But if you had to operate, we're not letting you get out that easy.
You
So
say
if you
that-
had to do surgery,
So if surgery is indicated, then I agree with the plan. T10 to pelvis would be the way to go, followed up by teriparatide.
no. So just doing an L5S1 limited fusion. Yeah, I think that's what they had attempted unsuccessfully about 6 years ago. You know, so I would say with a patient like this, my thought is you probably have one chance, right? So I think with somebody who, especially who's on chronic steroids, who's already been treated for osteoporosis and all these things, has multiple joint replacements, I think either you do no surgery or you sort of say, okay, I'm going to just try to fix this, because it's always hard to understand where the next problem is going to come from. So this is a person I did as a staged procedure. So I did multi-level laterals. This is the intra-op film, and then I got standing films the next day, so you can see, you know, sort of a very nice correction, immediate resolution of her back pain, because she can now stand without falling forward. This was at a time when I was doing these staged, so I staged this in order to understand if any radiculopathy symptoms that a patient may have would improve. And you can see just by doing laterals what kind of you know, sort of correction you can get in this kind of a deformity with stability. And then the next day we bring her back, and then we do screws down to the pelvis. And I was able to spare the thoracic spine. I didn't think that she needed a thoracic operation. I thought that we could stop at L1 like we did, because she wasn't really falling over specifically at that area. So I thought, you know, we got a decent outcome here. You can see the AP and laterals, and she's about now 4.5 or 5 years out from surgery. And then I'll just quickly go through a second case and just talk through it. But this is a different patient, 65-year-old female, who has more radiculopathy type of symptoms, but a lot of back pain as well. And this is how she presents. And you can see sort of really leaned forward and off to the side, so coronal and sagittally imbalanced on standing. And you can see how much she's bending her knees. And anytime I see sort of this much knee bending and sort of this sort of straight looking spine, you know, I always think about the stenosis. And so the similar case as we saw earlier, you know, with a fair amount of stenosis impacting the lumbar spine. But I was concerned because of her back pain that I did think that she was somebody who wouldn't just be appropriate for an isolated decompression only, given how collapsed her L2, 3, L4, 5, and L5S1 levels were, and the amount of back pain that she had. And here's her CT scan. But again, you can see when she lays down, she really straightens out both in the coronal and the sagittal planes. So this is something where, you know, we've started to do more prone lateral surgery, and I think doing prone positioning using the robot. You know, we sort of hyperlordose and put the patient in a position on the table to hyperlordose, put in our screw fixation, and then come in prone using the robot and navigation, which allows you the ability, if you want to do a direct decompression or any kind of facetectomies, that you can be able to access. And then we have a camera that we sort of put on the tube so that we can sort of work within that lateral window. And we can get a pretty nice correction. I'll just kind of skip to the end here, but you can see here that this was without doing any laminectomies or anything, so working outside of the spinal canal the whole time. And here we stopped at S1 because we only went to L2, so L2 to S1, instrumented posterior and done in a prone position. Interesting. I think I'll stop there unless anybody has any questions or anything like that. Otherwise, we can move on to the next. Thank you.